On behalf of the Centers of Medicare and Medicaid Services, the Administration for Community Living, and the Indian Health Service, I would like to welcome everyone to the Long-Term Services and Supports webinar series. This is a monthly webinar series held the fourth Wednesday of each month on varying topics related to LTSS in Indian Country. Before we begin, I'd like to highlight the main features of your webinar interface. First is the main window where you see the PowerPoint slides. To the bottom right of the window is the Q&A pod. You can enter a question for our presenters at any time in the Q&A pod. Today's question and answer period will be at the end of the presentation. If you need technical assistance during the webinar, please enter your tech support questions in the Q&A box. Our tech support staff will be monitoring these questions throughout the webinar and will work to answer your tech support questions right away. You will receive an answer in the Q&A box. Finally, please be aware that today's webinar is being recorded and that the recording will be made available online in the near future on cms.gov. With those announcements made, I'd like to welcome everyone to today's webinar. Today's webinar is titled Culture and Health, Diabetes Care in Indian Country. Today we will have a panel discussion with representatives from 4 tribal and urban programs. During this panel discussion, we will ask our panelists to tell us more about how their program supports the long-term care needs of its community members living with diabetes. We will also learn more about how their programs are funded and how this funding benefits their programs to effectively serve their patients. The panelists will also provide information about how they face current program challenges and how they are working to mitigate those challenges, as well as tell us about the strategies and approaches to diabetes care that work for their community. Lastly, the panelists will share how integrating culture within their program services empowers their patients and community. Today, we will have 5 panelists representing 4 diabetes programs, both tribal and urban. My name is Julie Cahoon, and I will be the facilitator for today's discussion. Our panelists include Dr. Kendall Shumway, the Diabetes Director for the San Bernardino Riverside Indian Health. Lucinda Charleston, the Acting Program Director for the Special Diabetes Program from Navajo Department of Health. We also have Jamie Lozo, who is the Diabetes Program Coordinator for the Confederate Salish and Kootenai Tribes Tribal Health. We also have Rose Vasquez, the Diabetes Program Coordinator from the Urban Intertribal Center of Texas, as well as Morningstar Spencer, who is the Patient Benefits and Referral Coordinator. I just want to quickly thank each of our presenters and panelists for taking the time to share more about how your community is supporting individuals living with diabetes. Our first topic today is about diabetes programming. So I want to go ahead and turn to our panelists to respond to a series of questions. Each panelist will have an opportunity to respond on the topic. So for diabetes programming, Rose, can you tell us a little bit about your program, the type of services offered, and how the diabetes program works to improve the quality of those living with diabetes in your community?
Sure. So our diabetes program is a team of different providers, and we all do a good job of working together. So we have an MD, a physician assistant, a nurse practitioner, dietitian, RN, and a community health worker, and also an in-house pharmacist. So we have our diabetic appointments for our patients. We also have one-on-one dietitian appointments. We do our foot and eye exams for our diabetic patients, and we also offer everything such as cooking classes, a monthly diabetes support group, and we also have a community garden on site. And although we could use more resources, I feel that our center and our program is more of a one-stop shop kind of thing. It makes it easier on the patient to take advantage of what we have to offer, which I feel results in better adherence to their surgeons.
Great. Thank you for that. And Jamie, can you tell us a little bit about your program and the types of services offered and how the diabetes program works to improve the quality of life for those living with diabetes on your community?
Yes. Our diabetes program is within our tribal health facility. We are located, there's 5 different sites throughout the reservation. Our primary site is in St. Ignatius. Our program consists of 2 main objectives. We have our diabetes self-management education and support program, and then we also have our diabetes prevention program. Within our DMSDES program, we hold classes, 3 classes throughout the year. We also have dental referrals where we see patients one-on-one who have seen a dentist, and that we sit them down and we have education sessions with them. We also have provider referrals from our clinic at each of the sites. If our patient is in the clinic with the provider can leave the room and come and get us to have our education session or help them with whatever needs they need. We also will do home visits. We'll go to, if the patient is more comfortable within a home, their home, we'll go to them. We do medication follow-ups. We help our providers with insulin titration, and then we also hold one-on-one sessions with patients outside of the office. And then also, if needed, we do family sessions. That's kind of our diabetes self-management education and support program. On our diabetes prevention side, we have diabetes prevention classes that we hold throughout the year. Typically, we can get 3 in during a year. Also, our diabetes prevention coordinator will hold individual sessions for patients. She will also do exercise assessments and make an exercise plan. Also within the diabetes prevention, we hold youth activities. One of our programs that we do is a youth leadership camp during the summer and then an after-school program. The final thing that we do in our prevention is we have a community community-driven fitness group that focus on running and walking, and that they're called the Community Keepers. And the Community Keepers are really focused on promoting physical activity within each of the different communities on the reservation.
Great, that's really exciting. Dr. Shumley, can you tell us about your program and the types of services offered, as well as how the diabetes program works to improve the quality of life for those within your community living with diabetes?
Sure. We are a tribal program. We represent 9 tribes in Southern California. We're about 60 miles east of Los Angeles in the Inland Empire area. We were involved as a diabetes program with improving patient care. Some people might be familiar with the IPC program several years ago, and that really helped us, I would say, become more patient-centered in our approach. We're much more involved in the clinics than we used to be, being there to support patients when they're in any of our clinics. We have 7 clinics that are spread out over a large area. We have 3 educators. One's a nurse, an RD, and then we have a master's in public health. Those 3 are educators. We have 2 fitness specialists, 2 telemedicine staff members, an LVN and an MA, and we have a mobile unit with a driver that does eye screening out in our communities. We do a lot of community engagement. We try to be where patients go. So if the tribes are hosting events or TANF is hosting events, we partner with them and we try to be involved there. We do quite a bit of public health or case management, population management, where we look at our data and look at people that maybe we're not reaching, that haven't been to our clinics in a while, or their blood sugars are not doing well. So we do a lot of population management that way too, where we can give data back to our board and to our providers on the health of our patients. We do education classes and different types of activities, conferences, hosting walks and things like that as well. And then just trying to make sure our patients get access to the care they need, which is partly through a telemedicine program, which I think we'll have a chance to go to a little bit later. So, those are some of the areas that I would say are our focus.
Okay, great. Well, thank you all for sharing more information about your programs. It sounds like everyone is doing a vast number of services to try and engage their community and to try to promote healthy living as well. That's very good. So we'll go ahead and move on to our next topic. So this topic will be about program funding, to learn a little bit more about how your program is using current funding streams to improve the efforts of your services, as well as what some of the funding sources may be. So Rose, could you go ahead and start us off, and can you tell us about how your program is funded and in what ways this funding has benefited the diabetes program or services offered?
Sure. So our diabetes program is I grant, which is a special diabetes program for Indians. And it's done many great things, not just for our program, but programs all over the country pretty much. So primarily it allows us for us to pay for some of our employees. So a lot of our income comes from this actual grant. It also funds some of our incentives that we have. For example, we have a shoe program that we offer for our patients when they come in. They have their foot exams done. We're able to hand them a pair of Nike shoes. So the funding for that comes from that grant as well. It also pays for some of our supplies, our A1C tests, stuff like that that is vital to have done after diabetic checkup appointments. So it basically makes it possible for us to have the program that we have now. And I think without it, we wouldn't really be able to focus so much in the actual diabetes aspect of everything. And like I said, there are numbers and statistics that prove that the SDPI grant has helped not only us, but like I said, all the other programs that it does help fund.
Great. And what was the name of that grant one more time?
Yeah, it's the SDPI, Special Diabetes Program for Indians. Okay. And it's a grant that's coordinated by the Indian Health Service.
Okay, great. Can you tell us a little bit about the grant? Is it a 5-year grant, or what is more of the structure of that particular grant?
Sure. So it is a 5-year grant. It has measures that we, try, or goals that we try to meet. Yearly goals. We have to submit yearly reports also for it, show what we are doing, with the actual funds, how it's been helping us. Yeah, that's about it.
Okay, great. Thanks for providing that extra detail. Dr. Shumley, can you tell us a little about your program and how it's funded and the ways that funding is used to benefit the program?
Yeah, we're a lot the same. We're primarily funded with the SCPI program as well. Maybe just a little bit more about that program. It is Congress has to act to authorize those funds. And so it's not incorporated in the funding of the Indian Health Service as a whole. So sometimes Congress has funded 2 years, sometimes they've funded 5 years, sometimes even just 1. So sometimes that is one of the challenges, is that we're not sure if, Congress, we're waiting for them to act. So like this last year, when they were working on all the budget deals and they hadn't quite got around to funding the program, then it was caused a lot of anxiety on our end. We weren't sure what would happen with the grant, but in the past they have come through. Congress has come through but they actually have to pass a law. So right now we're in the second year of that 5-year period, but they have not authorized the final 3 years. So right now the funding will end at the end of 2019.
Right.
So although that's primarily our funding, we're always looking for other areas that we can increase because we really don't have the resources we need. When you have over 50,000 patients and just 3 diabetes educators, that's in a clinic. It is really a challenge. So we have recently partnered through a PCORI grant, the Patient-Centered Outcomes Research Institute. We partnered with the University of California at Riverside and their anthropology department actually to do that. And we've had to work on just building our trust between those two organizations, honestly. So it's been a slower process, but that's okay. We realize that if we need other resources. We've done some smaller grants, tobacco grant we got through the CRIB organization, of other few things like that. But as far as funding positions for staff members, those are harder to get. Those you need bigger grants, but sometimes they're small. Just with the staffing we have, it is nice to be able to look for partners that have researchers and that would be able to get some of those larger grants. So we are working on that relationship with the University of California, Riverside, hopefully in the future where we can get some of those bigger grants through the Institute of Health and the CDC.
Great. Thank you for that information. It sounds like there's funding resources is always a challenge. Jamie, can you go ahead and share a little bit about your program's funding and how those resources are used to improve your program services?
Yes. So we are also funded primarily 100% by the Special Diabetes Program for Indians, SDPI. However, we are in the process of trying to get our diabetes self-management education program, that side of our program, to be accredited. And once we're accredited, we'll be able to do third-party billing for that service. But right now, we're just primarily, all of the positions within my team, there's 4 of us, is paid out of the SDPI grant. Our grant amount increased 2-3 years ago. So with that increase, it substantially helped us really approach how we do our programming differently. We're able to extend and bring on more technology. Some examples that we've done is that we've brought on CGMs, which before we weren't able to because we didn't have the funding, but since our SDPI grant increased in funds, we were able to bring on CGMs, which has helped our providers and also helped the patients realize what's going on with their blood sugars, because it is retrospective, but they still get a look back and look at the raw data and see during the day and time, every 5-minute increments, what their blood sugar was doing. So that's been very helpful for our patients and also for our providers. The additional thing that we've had within the area, within the reservation that we work on, we don't have a lot of patients with type 1 diabetes. And so we haven't been able to really provide a lot of services to them. But with the additional funding that we've been able to do, we've been able to help assist these patients who've always wanted a pump, get a pump by helping them with their co-payments. So they have insurance, but sometimes they just start on a pump at thousands of dollars, $2,000, $3,000 just for the co-payment for the pump. And so we've been able to provide the support service to them, and then also help with the co-payments for monthly supplies. So that's been 2 of the biggest things that we've able to add. Some current things that we're trying to work on right now is what Rose was saying about shoe program. We're trying to reinstate our shoe program. We did have a shoe program a couple of years ago, but it kind of fell to the wayside. And so now we're trying to reinstate that. So that's something that we're looking forward to doing. And the additional thing that we've done was add the summer youth program, like I said before, to help really promote healthy lifestyle, promote healthy living among our youth. Recently, we've had, within the years, we've had increased youth suicide. And so with Healthy Lifestyle, we've collaborated with our Reason to Live Native, which is our suicide prevention, and also our tobacco program to really focus on our youth and to help promote Healthy Lifestyle, which incorporates diabetes prevention. So those are some of the 4 basic things that not basic, but some of the things that we've been working on. We do quite a lot within the program with additional funding, but yeah, anyway. stop right there.
That's great. That's some really good information, and I feel like all of the details that you shared really provide an insight into how diabetes programs across the country and within Indian country are able to manage their programming. So this is very important information. So thank you, everyone, for responding. So we'll go ahead and move into our next topic, which is program challenges. While everyone is doing great work toward providing services, we also need to recognize that there are challenges, and oftentimes programs are working through these challenges right now. And so we're hoping to kind of just talk a little bit about what some of those challenges might be and what are some of the ways in which your programs are working through these challenges. So, Dr. Shumway, can you go ahead and start us off and tell us a little bit about some of the challenges that your program is currently facing or has faced in developing and implementing diabetes services within your community?
It's transportation is up at the top, and that has always been one of our challenges. We Riverside and San Bernardino County are two of the largest counties in the United States, and so we cover both of those counties, and 7 clinics are pretty spread out. So even just, patients individually have challenges getting to some of our events, or we do have some limited transportation help, but it can be a challenge. We haven't been able to always help our patients get here. There are some incentive programs that we've been able to budget, where they can, if they come to some of the different events, then we can help them with a gas card or something like that, although it's a small amount. The other way we have tried to, over the last several years, is we've developed a telemedicine program, and that was, that really took us about 5 years to get where we're at, where we were purchasing some of the different equipment. It has to be secure, and so some of the equipment has been we now have 2 half days a week where we have an endocrinologist that sees our patients through that program, and that's been a real big help. At first, we were concerned patients wouldn't want to see a doctor through a screen, but we really found that patients enjoy the physician, an endocrinologist, and the endocrinologist is credentialed within our system, so they can use our electronic health record and help manage the patient. One of the other areas is just our limited staff. So we really do try to partner, and instead of hosting some of the events, we try to support what happens in the community. We partner a lot with our TANF program, the Tribal Assistance for Needy Families, and go and hold events and teach classes when they're having events there. So partnering with other community partners has been an important thing for us too, because we just can't cover and be everywhere we would like to be. Those are the 2 of the areas I think that we've tried to address with our challenges.
Great, thank you for sharing those. Jamie, can you go ahead and tell us about some of the challenges that your program has faced in developing and implementing diabetes services within your community?
Challenges, transportation is probably is definitely our top challenge. It takes 20 minutes just to get to anywhere here on the reservation. Our biggest city is an hour away, and the city is only 60,000 people in the population, so transportation is an issue here on the reservation. We have a very high poverty rate, so a lot of our patients do not have vehicles to even get around. We do have within the tribe, we have a transportation program, so they do transport, but they only transport Monday through Friday, 8 to 5, so which is a challenge for some of our patients. Then for our events that we hold in our classes, we do offer transportation through our community health representatives in each of the communities. So if we have a class in a particular community, that community health representative will go out and get patients for us for that class, which is helpful. Then we also have within the tribal health department, we have our own transportation program, but they are busy transporting patients to and from off the reservation appointments or dialysis patients. So a lot of times they aren't available for us. Those have been some of the challenges for transportation. Additional challenges that we've had is childcare. Within the reservation here, we have a lot of our elders who are taking care of their grandchildren. So even though they would want to come to our classes or our events, they have their grandchildren that they need to take care of. And so to really help with that particular challenge, we provide childcare at our classes and we provide childcare at our events now. But that in itself has a whole slew of problems too, because we need to have childcare, but the participants who are providing childcare have to be certified. It was decided by tribal council, not tribal council, but our department head, that they need to be certified in childcare. So trying to find available people for a couple hours to provide services, childcare services, has been quite interesting. And then on the administrative side, getting into this position, found out really, really fast that if you wanted to do something, for example, I wanted to purchase some incentives through the American Diabetes Association. Trying to get a W-9 from some of the larger organizations just to order incentives has been a challenge. And then also for the pump assistants, going through these different companies that supply pumps has been interesting to get a W-9 from, or even anything from them. Multiple times I've sat on the phone 30 minutes in the wait line just to get a W-9 for somebody so I could pay a bill for a patient, or just get a W-9 just so I could buy incentives. That's been a challenge. And so how I've done that is a lot of pre-planning. So if we plan a class, we're planning almost 3 months in advance. But with that, those are my top 3 challenges.
Great. Thank you for sharing those, Janie. Morningstar, can you tell us a little about some of the challenges that your program faces in developing and implementing diabetes services within your community?
Yes, I think our biggest challenge is the resource that we still lack, primarily due to funding. For example, we could use different diabetes medication and supplies in our pharmacy. We could use a podiatrist here instead of referring out to the nearest IHS facility. And, of course, like everyone else, we have a lack of transportation for our patients. Being we're the only facility in our state, the issue is primarily the patients not being able to make it to their appointment because of lack of transportation, specifically due to distance. We do offer gas cards, but they're only in $10 increments or bus passes for local patients, but those coming 5 hours away, 8 hours away, it's an issue to try to get them here. And even with that, it's still, we're a primary care facility, so we're not able to do a lot of the services that they're thinking we can do. But we do try to pair, like recently we paired with Choctaw Nation in Durant, where we're able to get not only the diabetic patients, but any of our patients transportation once a month to their facility as well. But that's probably the main thing is the distance.
Okay, great. Thank you, everyone, for sharing what some of those challenges are. I know that transportation tends to be a common theme across many programs within communities, and so it's an ongoing challenge. But it sounds like each of you have found some way to kind of mitigate that. So we'll go ahead and move on to the challenge counterpart and talk a little bit about successful approaches. So Jamie, can you go ahead and start us off with some of the successful strategies or approaches that your program has used to improve the quality of life of your community members living with diabetes?
Yeah, I think I was thinking about successes. As a program coordinator, I always think of all the negative things, and it's really hard to look at the positives. Which we do after I reflected and talked to my team members. We do have positives. So the biggest thing that I feel has been a huge success is our patient-centered outreach, specifically with our our insulin titration, working with our provider. One provider, we're able to reach out to our patients, get their blood sugar numbers on a weekly basis, and then give those numbers back to the provider. And he can give us a verbal order because we are nurses. Give us a verbal order. Then we take that verbal order back to the patient, and that the patient can get titrated to their insulin dosage faster than having to wait every 3 months or every month to come back in. And so that way the patient is easily better controlled faster than having to wait so long between visits. This also helps build a rapport with the patient by hearing us every week, calling them, getting their numbers. And in addition to that call, we also ask about how they're doing and what some challenges they've had this week. And so that also builds that rapport. So that's been a really good challenge by having, There's really good success by having it really patient-focused. If a patient doesn't want to come to the clinic for some reason, we do have elders that just don't want to come to the clinic, and that's fine. So we're able to go to them. And so we've had a lot of really successful home visits to where we're able to get into the patient's environment where they're comfortable and they're able to open up about their challenges. We're also going to see how they're living. If they need additional services, we can reach out to our elder programs or to different other programs within the tribe to say, hey, this patient needs assistance with a grab bar, or this patient needs a different runway, or this patient needs a walker. And so it's not just diabetes care that we're providing, but we're providing care across the spectrum, which is really helpful for some of our patients that don't want to come to the clinic. The other thing is that we have strong connections with our providers, which is really helpful, like I said before, but also with all the other programs. Because, like I mentioned before, we had the suicide prevention, we have tobacco program, we have the WIC program, we have DHRC, which is our tribal assistance program. And so with those really strong connections, and like I said, with the patients in the home, it really builds that rapport with them. And then there's different events that we've had that's been super successful. In February, we hold a Go Red event, which we really talk about promotion of heart disease awareness and among women. And so those events have been very successful. A lot of work, but they've been successful. And then we have a diabetes conference every year, which is very successful also, that we provide diabetes education and information with keynote speakers, and then also our classes. We just started a class 2 weeks ago, and we have 30 participants in that class, which is a large class for a diabetes class, but that is a huge success for us. We typically don't have 30 people in a diabetes class. We usually have 3 or 4, but it's been week number 4, and we're still up there with the numbers. So those are some of our successes. How we made it successful. Just keep on doing it over and over again, trying different approaches, advertising differently, word of mouth. It's just a lot of work, but it's fun work that I really enjoy to do. That's all.
Great, thank you. That's really exciting information. It sounds like your community has found a way to really connect with your community in an effective way that makes them feel as if they can approach your program. So that's really exciting. Morningstar, can you share some successful strategies or approaches your program has used to improve the quality of life of your community members living with diabetes?
Yes. Despite the challenges we face, we still continue to build relationships, not only with our patients, but with outside resources. This is still a place that our patients greatly depend on. We have the majority of our patients that are uninsured, and this center is the only place that they can come that will serve them and help them with the management of their diabetes and other health conditions. It's a great place for patients to come together as a community. Dental also has its own daily scheduling of appointments specifically for diabetic patients. So from a scheduled medical appointment for a patient, if they see that the patient has never seen our dental, then it's kind of a working relationship where they could just go over and ask our dental office if they have any spaces still available, and they're able to get those dental patients right into the dental suite so that they're able to care, not only medically but for their dental needs as well, just for full round health of the diabetic patient.
Great. It sounds like a really good approach to working with your patients within the diabetes program. That sounds very exciting. Dr. Shumway, can you round us out on how your program is using successful strategies or approaches to improve the quality of life of your community members living with diabetes?
Yes, thanks. This has been really fun to hear the other programs as well. It's exciting to hear how they're doing that. Some similar things. I think for us, just we're being successful being where our patients are, and that can be at a community event and then also partnering in our clinic. And like Jamie mentioned, partnering with physicians and things. I think that has been important. So we're there as a support to the doctors as well, and they in return of them supportive of us. We have a yearly conference. This is our 13th year. This August, we'll be holding. It's an all-day event. We typically have 3 or 4 speakers, and then some different either crafts or interactive type of activities, Zumba or native dancing. So anyway, we've had all kinds of different things we've done over that time, but that has been very successful, and we usually get about 300 patients that come to that. It didn't start out that way. First year we had like 40, and then it just built over time. So that's been exciting and successful. And I really think one of the things that did here, because we've been doing it for so long, is it's just created a kind of a can-do attitude in our community where we talk about diabetes, we talk about how to be successful, and I think that's helped our community approach diabetes in a much more positive way, where it used to be even kind of shameful to talk about diabetes openly. One of the things we're excited about right now is we're calling it a diabetic-friendly environment. But we had 2 of our staff members that went to Albuquerque last year to the Indian Health Service conference they had, and they heard the American Indian Cancer Foundation did a presentation on how to develop programs in the community. And so we came back and got excited about how we were going to do that. And we went to our board. We went to our strategic plan meeting that our board had. We asked if we could present and how would we want to have a diabetic-friendly environment. What changes would you envision if we were going to be more friendly for diabetes and prevention of diabetes? And so it's kind of become a campaign now. They've given us, our board has given us permission. We formed a committee with some board members and also staff members from different departments. It'll be wide-ranging from the food we serve to the snacks we provide, how patients feel when they're in our clinics, and then hopefully we'll spread to some of our tribal organizations as well over time. But just being politically active, I guess, is one way, but it's been it's already had an impact on different areas. So it's just just a way to organize and improve and help us have better health in our community.
Oh, that sounds really good. I like that. It seems like your program has really adopted a philosophy and a way of thinking and the way that you approach your work that seems to really influence how you're able to implement your program work. So that's very exciting, and I really like that a lot. So we have for our panelists one more question, and so this topic is about integrating culture and practice. So Morningstar, can you go ahead and start us off in telling us more about how your program has integrated your culture or Native culture as part of the programming? And can you give a few examples of how this benefits or empowers the patients that you serve?
Well, we always try to keep our educational materials culturally sensitive. Usually we will search for anything offered by IHS first. For our cooking classes, we incorporate native foods such as different squashes and corn. Our community garden is focused around native plants. The educational TV programming in our lobby is ran and directed by the Indian Health Service. So all programming is strictly directed towards Native Americans. Lastly, our design and decor involve different Native artists and local artists. We always try to focus on attending any IHS or tribal health conferences to bring back specific education and feedback directly from tribal leaders across the country. These are the things that contribute to having the patient feel like this is close to home. The Native and educational materials can be seen as coming from reliable sources, and it helps us reinforce that trust with the patient.
Great. That sounds really exciting. I know working with multiple tribes in one area can be important to integrate as much of each of those tribes as possible, and it sounds like you've found a way to do that. That's really exciting. Dr. Shumway, can you share more about how your program has integrated culture into the programming and how this benefits and empowers your patients?
Yes, I would. One thing that is so important, I think, is having some staff members that are Native American. I'm not Native American myself, but the times when we've been able to have people on our diabetes team that are Native has just made such a difference. They are just connected with the community. They have great ideas that help us reach people, and so just having people involved that understand that and it can help the rest of us do better. That has been very helpful, and I think is very important. It has always been possible, just with staff we've had, and for hiring a nurse or an RD. We haven't always been able to find Native staff, but that's been very important. I mentioned our the conference we hold yearly, and again, having Native staff involved in the planning of that. We first started out when we first began. We had we always begin with a blessing. We invited Native dancers to come and do things there and singing. And I think over time, what I've seen just even in an organization, a lot of times now, at any meeting we have, they have a blessing. I just love seeing that happen, where people are much more open to bringing that emotional and spiritual aspect into our healing. So those are important, and just traditional activities that. Whether it's feeding or Native dancing or whatever we've done, we've tried to incorporate those kind of things. Right now, I mentioned our grant that we're working on with the UCR. And one of the reasons why we're working with the anthropology department there is we're working on historical trauma, and this is something that we were nervous to jump into, and yet an important area. And so we're beginning to work on having that discussion in our communities as well, and including our providers that are not Native into that discussion. That I think will be important for us as we progress in that area. Those are some areas that have been important for us.
Great. Thank you for sharing those details. It sounds like your program is finding a way to make it work and to connect with with Natives within the area. Jamie, can you tell us about how your program integrates culture into as part of your programming, and can you tell us how this benefits or empowers individuals that you serve?
Yeah, so with our program, like I said before, we have 4 diabetes, primary diabetes on my team. There's myself, my diabetes nurse educator, my diabetes nurse, and then my diabetes prevention coordinator. We are all enrolled members of the Confederated Salish Kootenai Tribe, and we've all grew up here on the reservation. It just so happened to happen that way, and by us all being here, having lived here, we have that rapport with our patients that is just innate. Once they get us in their home and they're like, oh my gosh, you know so and so, you're related to my dad, or you this or that, and so that right there just builds that connection. It's not really a cultural, it just happens, and so it's been very beneficial to the program because our patients can connect to us on that level. In addition to that, being part of the culture and growing up here, we know that every one of our events are opened with a prayer. It's opened with an honor song. It's opened with a flag song, and then our honor guard, who is primarily made up of tribal members, also presents our flags at every one of our events, which is very helpful because it opens kind of the spiritual side of healing, but it also really gives the connection to our patients. Like, okay, this is our event. It's nobody out from outside coming in. It's our event. So we have 3 tribes. We have our Ponderay tribe, and then we have Salish, and then we have the Kootenai. So we try to bring in elders from each of the tribes we kind of switch off each event that they come into. With that, one of my diabetes nurse, she grew up here. Her dad was an elder, and so she's older, 65. But her being here for so long, she knows all of our families. I kind of call her my cultural liaison because I can tell her a name, and she knows exactly that person's family, where that person lives, everything about that person. And so that's been really helpful. We had a provider call us and say he had a patient that had very high abnormal blood sugars, and he needed to go to the emergency room. So I told my cultural liaison, hey, this is the person, we need to go find him. And so she knew exactly where to go, knew exactly what to do, and she walked right up to the door, and the guy was pretty hesitant at first because he didn't know what was going on, but as soon as he saw her, he opened the door up and was talking about family and such. Unfortunately, he wasn't at that house, and we weren't able to find him that day, but he did get the message and he was able to seek medical treatment. But she's very valuable for being born here, raised here, is a respected elder. That's been super helpful with the program, the cultural aspects. Another thing that we do is we use the IHS Build Balancing Life with Diabetes curriculum. It's from 2012, so it is outdated, but the content is still relevant in a cultural way. So we just updated some of the information, but we still use that. And so patients really like to see the native designs on their handout, and that their people that they're looking at are actually natives and not other ethnic groups. So that's been helpful too. We also incorporate a lot of our craft projects to really revolve around cultural. So we have a sewing group in January that we host to really emphasize the open discussion about heart disease among women. And so during the sewing group, we provide all the materials to make ribbon dresses and wing dresses and ribbon shirts. And so the whole premise of this group is to really open the discussion of heart disease, but also provide a cultural aspect to it where you're sitting and sewing. And we also do beading, so you can sit around a table and bead and talk, but have the discussion kind of driving with a health-related heart disease discussion. So those are just some of the things culturally that considerations that we have here. But yeah, that's it.
Great. Thank you for all of those examples. It sounds like your community is really connected in a way with the folks working at the clinic and finding a way to connect with those within the community. And it sounds like each of your programs have found a way to value and incorporate culture as part of your daily work within your programming and services to your patients. So it's very exciting. Thank you all for sharing those examples and all of those details. So that will kind of end our panel discussion, and we'll shift into the question and answer session. And so if you have a question for our panelists, you can enter that into the Q&A pod located at the bottom right side of your screen. And as noted at the beginning, if you had questions, you could go ahead and enter those. So at this time, we have a number of questions in the queue. So I will go ahead and start addressing those, and I will try to direct each one to a specific panelist to respond to, and even do another round where each person can respond as well. So the first question is about patient outreach. The question is, do you seek out the patients, or do they come into the centers to find out about your program? Morningstar, can you go ahead and provide a response to this question about patient outreach and how individuals find out about your program?
We do a lot of outreach on Facebook. We do have a website that occasionally they'll update with some of those events that are upcoming as well. Sometimes we'll do mail out for specific events as well. But is that the only part of the question about outreach?
Mm-hmm.
The different types of outreach that we do? Yeah.
Yes.
Every once in a while too, if it's something big that we're really trying to, draw, as many people out as possible. Well, we do have a native local radio station that sometimes some of us will go to. That it's only there on Sundays, but a lot of our community knows about it and listen to it for any upcoming Palo Alto events that are going on in the area.
Okay, great. And Dr. Shumway, how do patients come to learn about your program? Do they often come to the center, or are there other avenues that they are able to learn more about the program?
I would say primarily when they come to any of our clinics, and we do better when we're there when the patient is there. So if we try to call them after the fact, or if they, if we see that they're a new diabetic and they're already home, it's a lot harder to get them back in. So that's one of the reasons why we try to partner with our clinics and be there as much as possible. So if it's a new diabetic, then we're there to sit down and talk with them and help them see what we do. We do mailings. We used to do a newsletter. We haven't recently. We've been working on possibly doing electronic newsletter. I mentioned our just data. All SDPI programs are required to submit an annual audit where you track patients. So those are some of the, that gives you a good way to look at the health of your population. We do, we can search for new diagnoses of diabetes and, reach out to them. Or, again, patients that haven't had certain screenings. We do a search, like for eye screening. We can run a search and look for patients that have not had that, and we'll reach out to them. And email, and sometimes send out letters even and say, here's some of the things that we would recommend that you have done. So we try to be there when they come in, because that's always better. But we also try to reach out in different ways.
Okay, great. And Jamie, can you share more about how patients are able to learn more about your program?
Yes. So our Travel Health just did a really big advertising marketing campaign, and we were part of that campaign. So patients, every Travel Health recipient received a packet with all the services that Travel Health offers, and we were in that. So that was one way. For certain events, we will do advertising in our local tribal newspaper, and then we'll also do radio advertising, our local radio advertising. We will do mail outs for patient outreach, but then also we do a lot of flyers, word of mouth. We do have a Facebook that we can, if we have an event that we're trying to promote, we can put it on that Facebook account for Tribal Health. Those are the main outreach, and then we've been such an established program. We've been here since 2000. A lot of patients already know about us. And then we also provide a lot of free support services. Like we provide $100 towards eyeglasses. So a lot of patients hear about those kind of services, and then they inquire further about what else we offer. And so that really reels patients into by just asking about one thing, and then we tell them about everything else we do. That brings more patients. There's a lot of word of mouth.
Okay, great. And this one question came in about what instruments are being used for the mobile retinal eye exams. I think this was Dr. Shumay that mentioned this. I may be incorrect in that, but is that something that you correspond to?
Yes. So we've had a couple of different types of cameras, and one of them that we've used for a long time is actually in this big, huge box. So it's mobile, but it can be a challenge. So there's a Canon camera that is, and it takes the image, and then we can save that image, and then we do have eye care clinics, so we save those images and let our doctors review those. I know there are some other programs where you can do it, where you send those images off to outside providers that can do that, and that we're lucky to have some eye doctors inside our organization. Recently, we've just, and again, this was through the grant. I think it was about, we had to write it into the grant, but I think it's about an $8,000 through ZEISS, or ZEISS. I remember how to say that, ZEISS. It's a smaller one. It's only about 10 pounds that our staff member will be able to take out and take those images. So the technology there is improved, so it's not such a big item. And again, we save those images and then get them back to our eye doctor so they can review and then contact the patient if they need further follow-up. So that's how we've been doing it.
Great, thank you for that.
I guess I should add, we can take our mobile unit anywhere. We haven't at this point. We've been talking this year about going to homes. We usually go to clinics, and our staff member will schedule patients that haven't had that exam yet. So they'll come in either to the clinic or to the mobile unit and get that eye exam done. Anyway, that's it.
Great. Thank you for that information. So we'll go ahead and we're running up close on the top of the hour, so we'll just take a couple more questions, and then we'll go ahead and wrap it up. This next one is about the diabetes program accreditation. Jamie, can you just share what are some of the first steps the program might take to become accredited?
Oh, yes. So first you have to choose if you want to be accredited through the American Diabetes Association or if you want to be accredited through the American Association of Diabetes Educators. Our program chose to go with the American Association of Diabetes Educators Accreditation. It was a long discussion on which one to choose. The AADE is, you can really say it's educator-friendly, while the ADA is patient-friendly. They're both patient-friendly. Their goal is to help patients with diabetes, but we went with the AADE. The first step that we really did with our program is we sat down and read all the standards. There's 10 standards to get accredited, so you have to read through them. And then we started really just kind of piecing together our program into these standards and just started at standard number 1. And we got all the pieces and documents in place and wrote it up. Then we did standard number 2 and standard number 3 and so forth. It's a process. It's time-consuming. And so what eventually happened after trying for a couple of years now is that we ended up hiring a pharmacist who came in and wrote all of our standards for us. And we contracted with her, and she sat down and worked with all the standards, and then she met with us, and then we went through the standards. And so now we're in our Montana State diabetes program educator. She's going through the standards now as a revision and kind of giving us feedback on what we need to do. And then once we're done with that process, we'll submit the application along with the standards. So it's a long process, but that's the first step.
Great. Thank you for sharing that information. So we'll move on to our final question. So the last question is about how have you used audit data to improve coordination of services between clinical services and community-based programs? So, Morningstar, can you go ahead and give us your response to that question?
I'm sorry, can you repeat that question one more time?
Yes. How have you used audit data to improve coordination of services between clinical services and community-based programs? If you want, we can go ahead and we can come back to you in just a moment. Dr. Shuma, can you provide a response to how you've used audit data to improve coordination of services between clinical services and community-based programs?
Yeah, I'm not sure we've done it. I think we've done it so we improve our clinical program. Like I mentioned, people that haven't had eye screenings, we use that audit data and who has not had the screening, and then we reach out to them and either go out to the clinics to come in. So, and then, or if patients have been into the clinic in 6 months, then sometimes we've done that where we'll call patients and say, hey, we just haven't seen you in a while. Or checking their A1C, which groups of patients have an A1C that is not well controlled. But I don't know that we've used that data to connect with community programs. I think that was what the question was. I don't know that we've taken that data to say, okay, what else in our community would help our patients? So we've used it more clinically than community services.
Okay, great. And Morningstar, I have just a different question for you. Can you tell us, what is the average age of participants in your program? And might one gender be more represented than another? And if you could share the percent who are on insulin.
These I wouldn't know. Rose is the one that kind of is over all any type of numbers. I'm sorry.
Oh, that's
I'm not on that front page.
Sure. Okay. And Jamie, could you go ahead and respond to what is the average age of participants within your program, and is one gender more represented than another? And if you can share an estimated estimate that are on insulin?
Yes. So the average age, predominantly, I just ran these numbers. We typically have our highest age group is 50 to 55, but predominantly everybody's over the age of 45. We do have some people who are in their early 20s. I think there's only 5 of those, and then we have some in their 30s, about 21 of those. So that's the average age. It's pretty split down the middle of females and males. Predominantly, we have females that utilize our program and seek us out for our diabetes education. Males are harder to get to. And then insulin, that's a hard number to capture. But we do have a lot of people. We still have a huge portion of our generations that believe that once they go on the shot, that they're gonna lose a leg, and so it takes a long time for them to get on insulin. But I would say I couldn't even accurately guess that. Even my guess could be completely off-shotted. I don't have that number.
Okay, sure. And Dr. Schumer, can you respond to that set of inquiries about average age and gender and percent on insulin?
Sure. I wish I had my audit right in front of me. Our average age of our diabetics is in the 50s. The patients that actually participate in our program is generally a little bit older than that. In fact, as part of our grant last year, we focused on patients 25 to 50 that were diabetic, and it was really hard because for the most part, those people are working, they're taking care of family. It's just like diabetes sometimes is not their, they're just so busy in other places in life, it's kind of a hard time engaging them sometimes. So, a lot of times the people that do participate are closer to retirement age or home during the day. So we realize that's a demographic that we would like to reach out better to. Percentage on insulin is probably about 25%. In some ways, we'd like to increase that just because there are patients that are not well controlled and should be on insulin. But again, like Jamie mentioned, it's sometimes that's hard to help people, convince people that they really do need it, that they do need hormone replacement. Their body is not utilizing the insulin they have, and we need to supplement to keep their blood sugars controlled. So we feel like it should be higher, but sometimes, we definitely work with the patient on managing their diabetes, and sometimes they do need it, but they don't want to. So, we're probably about 25%.
Okay, great. And so I know that we ran over a little bit on time, and so I want to be mindful of everyone's schedule, and so we'll go ahead and end our Q&A for now. For remaining questions that have been left in the queue, I will be able to follow up with webinar attendees with an answer to questions via email in an e-blast following this webinar. So again, I want to go ahead and thank each of our panelists for responding to the questions that were asked by the audience. At this time, in closing, I would like to remind everyone that today's webinar was recorded and that the audio and PowerPoint will be made available online at cms.gov on the Tribal LTSS Technical Assistance Center website. Thank you again for joining today's webinar. Our session is now concluded.